In this video, I'll be talking about advanced breast cancer, also called stage 4 or metastatic cancer. I'll talk about what it is, the different treatment options, and then a few very specific things you need to know about testing that should be done on the tumor. Advanced breast cancer is sort of a catch-all term for cancer that is also referred to as metastatic cancer or stage 4 cancer. I'm going to use advanced breast cancer throughout this video. It's just a more understandable term. Advanced breast cancer means that cancer has spread from the breast and the neighboring lymph nodes in the armpit or perhaps in the area above the clavicle to other parts of the body. This can happen before you're even diagnosed with breast cancer, where cancer cells leave the primary tumor, spread through the bloodstream or the lymphatic system, and sort of nestle in to other tissues like the liver, the lung, the bone. And to be honest, there are very few places where breast cancer cells won't find a home, but I've just mentioned the most common places. Now, two ways of being diagnosed with advanced cancer. The first and most common is that people undergo treatment for their primary breast cancer. They have surgery, maybe radiation therapy, maybe chemotherapy, targeted therapy, hormonal therapy, and then years later, the cancer comes back in other parts of the body. Does this mean that your treatment didn't work? It doesn't. It means that it just didn't work well enough. And without that treatment, the cancer may have come back sooner. So that treatment was not futile, but what you're living with now is cancer that has recurred, and it's in other parts of the body. That's different from cancer coming back in the breast. The other way people can be diagnosed with advanced cancer is at the very time they're diagnosed, they're found to have disease in other parts of the body. About 1 in 10 women in the United States, and actually worldwide, will have stage 4 disease at the time of diagnosis. This is also called advanced breast cancer. So what follows will refer to both types of advanced breast cancer. In people with advanced cancer, our goal of treatment is to help you live as long as possible with as good a quality of life as possible. At this point, we don't have treatments that can cure advanced cancer. I'm going to tell you about a small proportion of people who live many, many years with no evidence of advanced cancer. This is up to 5% of people who've been told you have advanced cancer that we can't cure. But in those women, including several patients I have who have lived with advanced cancer for decades with no evidence of disease, is it likely that the cancer could come back? Of course, and that's actually what we expect. So we continue to follow those women to assess and monitor the disease. But in most cases, the goal of treatment in advanced cancer is to improve your quality of life and prolong your survival. So it's a combination of the two. What this means is if you feel worse on treatment than off treatment, we need to make a change. We need to change the treatment plan. It's important that you talk with your medical team. It's important you ask questions and clarify, make sure you're on the same page. I can't cure this, so I need to make you feel as good as possible. That's what you want to hear from your doctor. This can be really hard for doctors to talk about, and even patients who are told this have a hard time hearing it sometimes. So that's a natural response to what is very serious news. How do we treat advanced breast cancer? Well, the first thing we need to know is where is it in the body? So you will find if you are diagnosed with, let's say, cancer that's recurred in the bone, that your team will order scans of your whole body. Not your brain in general, but really the rest of your body. So you'll have a PET CT perhaps, or a CAT scan, a bone scan, and then if we're not certain this is what it is, we would do a biopsy of the safest area to biopsy. Why do we do that? Well, we want to make sure this really is breast cancer. Sometimes we find a whole different cancer or even something that's not cancer. So the standard of care is whenever possible, if we think that your cancer has spread to other parts of the body, that you should have a biopsy of the safest and most fruitful area to biopsy. Now, the biopsy results can take a while, so be patient. This is something that you can ask for even if it hasn't been done. The other parts of your workup will be blood tests, including tumor markers, which we don't do in people who've been treated with an intent to cure. But about half of women with advanced cancer will have elevated tumor markers. If they're elevated, we can use them later on to see how you're responding. So we've covered what is advanced cancer and how you should be evaluated if we think you have advanced cancer. In the treatment of advanced breast cancer, we have many different treatment modalities we can use. In general, we think about hormonal therapy, we think about chemotherapy, targeted therapy, radiation, and even surgery in some patients. The treatment decisions are based on the tumor biology. Specifically, is the tumor hormone receptor positive? That is, does it have the estrogen and progesterone receptor? The other key feature we look at is whether or not there's HER2 positivity of the tumor. We have this covered in another video. If the tumor is hormone receptor positive, we generally use hormonal therapy. Why is that? It doesn't sound as aggressive. Well, remember, the purpose of treatment in advanced breast cancer is to help you live as long as possible, feeling as good as possible. Clinical trials have shown that people treated with hormonal therapy live just as long as people who start with chemotherapy. So we've achieved our goal of helping you live long. In addition, hormonal therapy is better tolerated than chemotherapy in general. And remember, we're going to keep you on each treatment as long as it's working. What if you got 5 years on hormonal treatment before we even had to consider chemotherapy? You feel much more normal, you can perform your daily activities. The decisions that we use to make decisions, the factors that we use to make decisions about hormonal therapy include whether you were on hormonal therapy when the cancer came back. If you were, we're going to switch to a different hormonal therapy. We also look at your menopausal status, and frankly, if you're premenopausal, we recommend suppression of the ovaries. Why do we do that? Well, by suppressing your ovaries, we decrease estrogen produced by the ovaries, and that allows us to use many more options using endocrine therapy, hormonal therapy for the treatment of advanced breast cancer. And again, it's better tolerated and works just as well. How long will you be on hormonal therapy? Well, we have so many options now in hormonal therapy. What we generally do is start with one, see how you respond, and I'll cover how we follow you in just a moment, but we see how you respond. If you have a good response, a durable response, meaning you respond for months or even years, when that treatment stops working, we reach for another hormonal therapy. So in general, in advanced disease, what we like to do is go one drug at a time and then go to the next drug in that same modality. So hormonal therapy A followed by hormonal therapy B. Now, at some point, most breast cancers become resistant to hormonal therapy. That's when we think about chemotherapy and targeted therapy. So when endocrine therapy or hormonal therapy isn't working as well, then we discuss with you the option of chemotherapy. Chemotherapy in the curative setting, which we've covered in another video, is given with an intent to cure, and we tend to use 2 or more drugs together, because what we're trying to do is give you, yes, a lot of side effects, but the goal is cure. Remember, I said the goal in metastatic or advanced disease is to help you live as long as possible, feeling as good as possible. We know from clinical trials that in most women, 1 chemotherapy at a time, followed by, when that stops working, another one, prolongs your survival and helps you feel better. That achieves both of our goals. How do we make decisions about which chemotherapy? That's based on a few factors as well. The first is the tumor HER2 positive? If it is, we'll use different regimens along with targeted therapy that targets the HER2 protein. So for example, if you have a chemotherapy that we can't use with Herceptin that you've never received, we won't use that because you need that HER2 targeted therapy. I'm hoping that makes sense. If you want to learn more, you can go to Yerbba.com and see your options based on the type of tumor that you have. Other targeted therapy in advanced disease is expanding rapidly and depends a lot on the tumor profile, and your tumor should be tested for different markers. Again, that's available to you on Yerbba.com, and it's personalized to what's been done to test your tumor or what hasn't. It's very involved to go into. We can have other videos in the future. If you're interested, put it in the comments. You want to learn more about targeted therapy in advanced disease, and we'll make another video. All right, so we covered hormonal therapy and chemotherapy. The term you'll see is single agent sequential therapy. Now there are a couple exceptions. If your cancer, advanced cancer has a big tumor burden, you have a lot of cancer in your body, sometimes because it works faster, we will combine two drugs together, but that's generally not the case. Now, targeted therapy, I've already mentioned Herceptin, and I've mentioned that there are new targeted therapies. It's important to know that most of those are given along with chemotherapy. Not all of them, but most of them are given with chemotherapy, and they basically help the chemotherapy work better. We even have some drugs where the chemotherapy and the targeted therapy are one drug together as we make more and more advances. We update the Yerbba platform in real time so that we can present any new advances to you right away. And we'll be updating our video library as well. So I've covered hormonal therapy, chemotherapy, targeted therapy, and all of this is based on a lot of things. Your previous treatment, how long it's been since your last treatment, might that treatment work again, and also particular features of your tumor. Now I'm going to talk about one particular type of hormonal therapy, which is ovarian suppression or ablation. In some women, this alone can lead to regression of the cancer. The tumor can respond just to having your ovaries suppressed with shots or removed surgically. And although it's less common in this country, radiation therapy over just 5 days can eliminate the function of the ovaries with very little toxicity. That's something you can explore with your medical team. Now I'm going to talk about specific treatment to specific sites in the body if you have advanced cancer. So what we've been talking so far is about systemic therapy. It goes through your whole system. Remember, these cells have spread through your bloodstream and lymphatics to liver, lung, bone, etc. Now what about specific areas? We're used to thinking about surgery for breast cancer. Why am I not talking about surgery yet? There are a couple cases where we would consider surgery. One is if your diagnosis is made and you still have a cancer in the breast, we obviously are going to treat the rest of the cancer throughout your body. That's the priority. That's the life-limiting disease. But sometimes we also see such a response in the breast tumor itself that if everything's going well, you're responding to treatment and you have what we call a durable response lasting months or years, many women will be offered a chance to remove the breast tumor itself. It's psychologically beneficial, it can help you feel like you're doing everything possible, and also, why not treat it while it's responding? So first things first, your whole system, and then we think about the breast. The key thing to know is that if treatment's working throughout your whole system, it's also working in the breast. When wouldn't we do surgery for somebody with a breast tumor still there who has advanced disease? Well, in some women, the disease in the breast disappears entirely. And so again, first things first, your whole system matters. And some women don't want to have surgery. I've had patients where the cancer in their breast is so extensive, it's responding so beautifully to treatment, they don't need to have surgery. This is a highly personal decision. you and your doctor should talk about. If surgery is not recommended, don't think that we're giving up on you. It's that you're doing so well without surgery. Couple other reasons to have surgery in advanced disease. These are specific situations that may or may not apply to you. One is if you have cancer in the bone, let's say in the femur or the long bone of the leg, and there's an area that's painful or that is at risk for a fracture. We call this a pathologic fracture because it's due to the pathology of the tumor. You might have surgery to stabilize that bone, followed by radiation therapy. This obviously is a very drastic event. However, the surgery is actually associated with a quick recovery time, and the radiation therapy that follows it is also short-term. The other scenarios in which we would do surgery is if you were to have cancer compressing your spinal cord, and this is usually treated with radiation first instead of surgery. There are some people where surgery is the best option. Other examples might include an area, let's say, around the lung, and you're developing fluid around the lung. We'll do a procedure to help keep the lung open. It's not really a surgery, it's done by interventional radiology, but it's another procedure. And then rarely people can have breast cancer recur in the brain, and for many people, surgery is necessary. In general, we use radiation. Next, I'm going to talk about radiation. I've already mentioned that we might use that in treating the bone after surgery, but radiation is extremely effective in treating symptoms related to advanced cancer. I'd say the most common scenario in which I've recommended radiation therapy is in people who have painful bone lesions. Radiation therapy is nearly 100% effective with a very short course of radiation. We're talking 10 treatments. Some people can even be treated with one treatment. Can you imagine you have pain in a rib or your back or your shoulder? We can treat this with one treatment. So this is an option for you. Even if the cancer is responding to your systemic treatment, sometimes we'll want to radiate that bone lesion because it's either severe or it's causing a lot of pain. So radiation is good for treating symptoms. It doesn't go through the whole body. Other situations would be as if you had breast cancer on the chest and it was bleeding. Radiation therapy works incredibly well for that without surgery. There's some other situations as well in which radiation therapy can be indicated. And your own Yerbba report will let you know if that's an option for you, but don't think radiation therapy is ruled out because this is a systemic disease. Finally, the last thing I'd like to cover is bone-directed therapy. For people who have bone metastases, cancers in the bone, the standard of care is to give what we call bone-directed therapy. This is medicine that you get to strengthen the bone. Interestingly enough, we use these medications to treat osteoporosis. You might know of Boniva, which we see advertised for osteoporosis, or Fosamax, and you may even have been on one of these medications or may be on it now. The problem with these medicines given for osteoporosis is we don't absorb them enough. Once you have disease in the bone, we'd like to give this through your system. Not like chemotherapy or targeted therapy. This is much more of a maintenance or preventative therapy, but interestingly enough, these drugs reduce pain, reduce the risk of fracture, reduce the need for surgery, and have very few side effects, which I'll cover in just a moment. There are two major types of bone-directed therapy. One are bisphosphonates, and these are given now every 3 months. It used to be monthly, but we know every 3 months is just as good. And you will stay on this medication for as long as you have bone involvement and there are no side effects. The other type of medication is called a rank ligand inhibitor, which is spelled over here. These medications are primarily denosumab. Other ones are being developed, of course. The brand name is Xgeva. And if you've been on Prolia for management of osteoporosis, it's the same medication. They just renamed it for different reasons, for different uses. This medication can be given under the skin. So if you don't have a port, a semi-permanent IV, and your IV is really difficult to get, you can get these medications under the skin. Now, these are difficult to get covered by insurance because they're very expensive. So we restrict these for just a few people who can't tolerate the bisphosphonates or people who don't have an IV. I said I'd talk about the side effects. The bisphosphonates can cause aches and pains until we get the bone disease under control. And for the first couple treatments, you can actually get a flu-like syndrome. This goes away, so don't give up. You'll get it with possibly the first treatment. We see this about 1 in 5 people. So 4 out of 5 people don't have this flu-like syndrome. Occasionally, people can get it with the second treatment. Most people just get it with the first. So try to stick that out because these medications are really a key part of managing bone involvement. A very rare side effect of the bisphosphonates is something called osteonecrosis of the jaw. You don't even need to know what that is to find that quite alarming. Basically, we see that areas in the bone won't heal. So if you have a dental procedure, it's possible, like if you have a tooth removed, that area may not heal. People who are at risk for this complication are people who smoke, who don't have great care of their teeth at the beginning, or who it's actually kind of random, but in general it's quite rare. What we recommend is before we start bisphosphonates, you see your dentist, have any work done that needs to be done, invasive work like removal of teeth, etc. And then you follow with the dentist fairly often. We don't have a lot of preventative strategies right now for osteonecrosis of the jaw, but there are several drugs in clinical trials. We'll keep you updated in the future if that happens. We don't see this side effect with the rank ligand inhibitors. The biggest side effect of the rank ligand inhibitors is something called fragility fractures, which is not so much a concern in people with advanced disease where we're treating known disease in the bone. It's more of a concern in somebody who might be getting preventive therapy for osteoporosis. And the other side effect, of course, is the cost. And that's a very real thing for most people. So I've covered a lot today. I covered what advanced cancer is. I've covered treatment options, what the goal of treatment is. The last thing I'd like to cover is how often do we follow you? If you've been treated in the adjuvant setting, you may not have been seen by your oncology team for a while, and you're wondering, what's it going to be like? In general, in people with metastatic or advanced disease, we see you whenever you're on treatment. The frequency varies, but you're seen either every chemotherapy cycle, or if you're on hormonal therapy, we'll see you every 3 months or so once we know the treatment is working. What about scans? Well, in early stage breast cancer, where we've treated it for curative intent, we don't do scans. They don't tell us anything unless you have symptoms. In advanced disease, however, we have measurable disease. We've seen it on a CAT scan or a bone scan or a PET scan or even on an X-ray. So we'll follow those exact same scans. We try not to switch it up and do a different test. We use the same test that identified the cancer, and we do those scans in the beginning, pretty much every 3 months. After you're in a partial remission or maybe even a complete remission, we'll follow you less often. The key thing is to know that if you have symptoms, that schedule falls apart and we will see you and evaluate you and see if you need to have a change in treatment. Just because the cancer may have started growing again doesn't mean there aren't any options. At some point, people with advanced cancer will be in a situation where further anti-cancer treatment causes more harm than good. And it's important to know that you're part of that decision as well. So in people where their cancer has not responded to 3 treatments, we generally start talking about what's called maximal supportive care or aggressive symptom management. So if you're not eligible for a clinical trial, what we would recommend is that you learn about your other options. Other options include managing your symptoms And in fact, you'll feel better off of chemotherapy. I've had people who didn't want to stop chemotherapy. I said, why don't we take a break? They've called me a month later and said, I haven't felt this good in years. And to me, that tells me we haven't been achieving our goals. And the second thing is they're going to get better quality of life by being, for example, on palliative care or hospice. I actually bring up hospice with all my patients when they're not even candidates. We'll cover this in another video because it's kind of a big topic to think about, but it's really important you keep lines of communication open. Why am I being treated? Is the treatment working? What's next if this doesn't work? And in my notes, I always say, if this doesn't work, this is my next plan. So you can ask your doctor, what will we do if this doesn't work? And they'll say, well, it will work. And you can say, I think so too. And if it doesn't, how many other options do I have? So be brave. You will find that you actually have more power the more knowledge you have. Make sure you get support from other people. Make sure you trust your doctor to give you honest information, but they need to know that's what you want too. You're basically giving them permission to be honest with you. Boy, we've covered a lot, and this is some heavy stuff. I wish you weren't going through this, but I do think knowledge is power. If this was helpful, like and subscribe to our channel because that helps improve the reach of what we are doing for other people. And in the comments, like I mentioned before, tell us what else you'd like to learn about. I love talking with you about what you're going through and ways in which we can help you.